Now you can hear me. So I swear we didn't coordinate our talks. We didn't speak to each other, but it really flows nicely. And I really have allotted half of my time for slides so that you all can ask questions of either one of us. So I'm going to talk a little about treatment, and why it's an overview is because there's a lot of different treatments and we couldn't possibly go through each one, and you'll see the list. So just following up from the last talk, when you're a patient and you're looking at literature or you're listening to a lecture, what do you need to know about your condition that you're interested in so that you listen to the right parts of the lecture, so that you're not listening to something that has no bearing on you? So you want to know, as was just talked, B or T cell. You want to know, does it grow fast or slow? The medical words is for fast is aggressive and for slow is indolent. That's just what we use when we're talking about lymphomas. Most skin lymphomas are indolent. Most grow slowly. You want to know the name. So if you come in and say, I have non-Hodgkin's lymphoma, I'm an oncologist that only does lymphoma. An entire 3 days of clinic of lymphoma. There's 75 different kinds. So when you say non-Hodgkin's lymphoma, it is meaningless. So you want to know the name, even if it's a complicated long name. You want to know the stage. You want to know what the treatment options. And when you're talking about treatments, you want to get down to the details. How's it given? Who gives it to you? Do you give yourself a pill? Does somebody give you an injection? Where is it given? How often? What are the potential side effects? And what's the goal? So we need to set expectations. When we have slow-growing lymphomas, usually the goal of treatment is to control the disease, make it go away. But oncologists don't usually use the word cure. Cure to me means it never comes back. And we use that when we're talking about aggressive lymphomas because we can treat them with chemotherapy and they truly never come back. But when we have a slow-growing process, it usually becomes a chronic condition that somebody has to manage throughout their life. So this is the same kind of a thing, and I'm going to talk mainly about the things in black because they're the most common T-cell lymphomas. There's a World Health Organization classification of T-cell lymphomas. It's this huge list of things. There's probably 25 of them, and there's a part of it that is primary into the skin, cutaneous, and the most common ones that we see are Mycosis Fungoides or Sézary syndrome, which is actually probably a slightly different disorder, and the CD30 positive lymphoproliferative disorders. And then we have all kinds of rare types. CD30 is a marker on the cell. There's actually a number of lymphomas that have CD30 on them, and the two most common that are primary to skin are lymphomatoid papulosis, which isn't really a lymphoma, as was described, and primary cutaneous anaplastic large cell. So those are the two CD30 positive lymphoproliferative disorders that are primarily in skin. In the B cell line, there's not so many things that are primary to skin. Actually, marginal zone isn't a primary skin disorder, but it can just lodge in skin. There's primary cutaneous follicle central lymphoma, not to be confused with follicular lymphoma, which is a different lymphoma. And then there's one aggressive type that you saw pictures of that, for whatever reasons, likes to present on people's legs. I know that's weird, but it's the truth. So when we're talking about primary cutaneous B-cell lymphomas, mostly we're talking about local treatments. So that would be, as you just saw in the case, radiation is a local treatment. When you radiate something, it's just like a flashlight. It only goes exactly where it shines. It doesn't affect anywhere else in the body. It doesn't go anywhere else. Exactly where the radiation therapist shines it, that's what's treated. Another example of something that's a local treatment would be for somebody to cut the lesion out. Sometimes that happens. Or a dermatologist to put steroids into the lesion to make it go away. Those are all examples of local therapies. When somebody has a lot of lesions for cutaneous B-cell lymphomas, sometimes it's just too hard to hit every single lesion. And so the patient might be treated with a drug called rituximab, which is an antibody that knocks out B lymphocytes, and you give it by an intravenous drip. In diffuse large B-cell lymphoma of the leg, that's an aggressive disorder, and those patients get combination chemotherapy, mostly in the vein. Kind of more what you would think about when you hear the word lymphoma. So this is an old slide from the the NCCN, which is a group of national comprehensive cancer centers that get together and they make kind of recommendations that community oncologists can use to see what are the treatment options. Am I on track? Am I doing something weird? Patients can also log in to the site. There's no fee. There's nothing but registration. And you see that there's a lot of different treatments. So we can't possibly go through every single one, though if you have questions, I've left plenty of time for that. So they basically divide up into two big areas. And is there a pointer on here? Maybe. Yeah. Okay. So there's skin-directed therapies and there's systemic therapies. Skin-directed therapies is just what it sounds like. They're things you put or shine on the skin. So the common things would be, you heard about using steroid creams on the skin. Sometimes we mix up chemotherapy in a gel form and apply it to the skin. Sometimes you might shine light on the area, and that's you're really just treating the skin. Whereas systemic therapies are things that go through the body, either because somebody takes a pill or it gets injected into them. And there's this huge list of things. So when I'm trying to explain to a patient which things I think are the best for them, how do I do that? I mean, I'm not just like throwing up a coin and going heads or tails. There's some rationale. So usually we think about using treatments not so much two at the same time, although we do that sometimes, but in sequence, one thing, and then we use it till it doesn't work anymore, or the person doesn't like it anymore, or can't get it anymore, I guess is another reason. And then we move on to the next thing. Sometimes we go back to the same old thing again. If the person's had a holiday from that treatment, we might go back to it again because it worked the first time. But primarily, we're picking the treatments based on the person's stage. So you can imagine if somebody has blood involvement, let's just say, significant blood involvement. If we put something on their skin, that is not going to treat their blood. So those are the kinds of patients that immediately get systemic therapies as a mainstay of their therapy. Whereas if somebody just has a couple of patches on their skin, primarily treating them with something that's going to go through the whole body is excessive because their skin can be treated. So we're going to look at what stage they are. Because we have so many choices, we're going to look at what's available for that person. Sometimes there may be a modality that's not available in your area. Maybe there's not a light box in your area. Then we're going to look at what's convenient for you. If somebody says, I only want to take a pill, and that's what I'm willing to do, then there's not so many choices. Then we go through the choices. And then we look at the short and the long-term side effect profiles and look at what other conditions does that patient have, so that we're not making something else worse. Also, knowing the therapies, we know that certain kinds of mycosis fungoides respond better to certain kinds of treatments. Certain kinds of treatments work faster or slower. So we might pick one or the other treatment for a patient given what the specifics are of their involvement, or do they need a really fast response because they're very uncomfortable, or it can take a while. We haven't studied combinations of therapy very much, although there are a few that have been studied, but probably many of you are on many things, and that happens a lot, even though we haven't studied it. And we like as much as possible to preserve people's immune system, because the immune system in lymphoma is really paramount to keeping the disease under control, all lymphomas. There's an interplay between the person's immune system and the lymphoma, and we need to keep the person's immune system fighting as well as it possibly can. So these are the kinds of considerations. So as I mentioned, the route. If you tell me I'm only going to take a pill and I'm not coming in to get an IV, then I only have a couple of drugs, and I'll go through those couple of drugs. If I know that somebody needs a rapid response, the fastest response comes from chemotherapy, even though we don't use it that much in skin lymphomas. Sometimes we do. There's something called an HDAC inhibitor. It works fairly rapidly, not quite as fast as chemo. And then there's things that utilize the person's immune system. They work much slower. The stage is very important. So things that utilize the person's immune system, they don't work very well on nodal involvement for some reason. They don't work so well with if somebody has organ involvement or even tumors sometimes. And so that's just something, even on, we will look at the long list. If somebody has a node that's involved, I might not pick something that, works with the immune system. There's certain drugs like retinoids, things that look like vitamin A, that work very well for tumors, versus something like photopheresis that doesn't work for tumors. And so we kind of look at the different treatments and what their strengths are. There's a newer drug, mogamulizumab. It works extraordinarily well in somebody's blood. It just does. So that's the kind of things that we look at. And then we look at the comorbidities or the other conditions that the patient may have, so that, as an example, interferon can hurt people's hearts. It can make their hearts pump less vigorously. So if somebody has a heart condition, that is not a drug for them. So we would kind of go through what other things is the person dealing with so that we don't make something else worse intentionally. And then there's always availability. So unfortunately, some of the oral drugs, they're extraordinarily expensive. If somebody's on Medicare and has a fixed income, there may be drugs that just aren't available because it's very costly. There may be things that aren't available in an area. So for instance, if your area doesn't have a photopheresis machine, it's not going to happen. You can't, be traveling hours and hours to get to a place. So these are kind of some of the considerations when we look at that long list. How do we weed through what's good for an individual? And then I'll show you a couple of pictures because the kind of disease often dictates the therapy too. So this is an example, a kind of a close-up, same kind of picture that was shown before, of follicular-trophic mycosis fungoides. So this is a person whose mycosis fungoides has decided to go along the hair shaft instead of stay up on the superficial level of the skin. And it's made the hair fall out in a patch. And when you run your finger over this patch, you see the little black dots, like here. It has a very distinctive look to it. And in all those areas, there probably used to be hairs and they're gone. Things like retinoids work extraordinarily well in this situation. It's just the way it is. So I know that when I see somebody like that, that may be one of the first things that I suggest to them. And just this is what the pathology looks like. This is a hair shaft. So all these blue cells, they're kind of clustering along the hair. Similarly, there's a lot of variants of mycosis fungoides, but this is one clinical variant. When people have darker skin, sometimes it shows up as light patches. And interestingly enough, probably the best way to treat this is with light therapy. So when I see somebody with hypopigmented mycosis fungoides, the first thing I'm going to do is try and find them a light box. So again, it's kind of examples of how you might pick different kinds of treatments for people. So there is these NCCN guidelines. They have suggested skin-directed therapies. They're very similar to the slide I showed you before. And then they have groups of systemic therapies. They're primarily for people that have more advanced disease or have run through all the skin-directed therapies already and either couldn't tolerate them or they didn't work. And now it's time to move on to systemic therapies. So this is kind of a way that they tried to organize it because it is a long list. So they made kind of preferred regimens in alphabetical order and then kind of next up. And so when somebody's maybe a physician that hasn't had as much experience, they may look at these lists to try and get a better idea of how to treat people. And you too could log into this site. It's nccn.org. It's, just to kind of see, sometimes it's interesting to see how close to what this particular group of physicians say your treatment is running. And then there's combination treatments. There's treatments specifically for people with Sézary syndrome. And this is just how this particular group decided, to organize it as an example. I'm going to call out 3 treatments that are newish, just to make you aware. The first 2 actually have gotten an FDA approval specifically in cutaneous T-cell lymphoma. And this is relatively recent, so it's a good example to you of how the field is moving forward. Susan was very kind to say I've been doing this for a while, but it's been almost 30 years and probably longer. And there's an enormous change in how I would have approached somebody in the 80s when I saw my first patients with Mycosis Fungoides to now. So you should feel very good that even though this is a not a very usual condition, that there's a tremendous amount of research and new drugs that are coming about. And these are some examples just so you can see. So brentuximab vedotin, I'll show you a little cartoon of what it is, or picture. Mogamulizumab, I just mentioned, is an antibody. Really our first antibody that we have in the T-cell space. Rituximab was revolutionary in the B-cell lymphoma space, and we've kind of been looking for our antibody. I'm not sure it has the same impact as rituximab does, but it's a step in the right direction. And I'm just going to mention pembrolizumab because you may have read in Time magazine or in the newspaper how people are harnessing patients' immune systems to fight off tumors. You know that President Carter had melanoma to his brain, and all of a sudden he's fine, and he used one of these drugs. There's one study looking at it in cutaneous T-cell lymphoma. I'm not sure I'm wholly convinced, but just so that you can see that people are applying these kinds of technologies and new medicines in our space as well. So brentuximab vedotin is an antibody, but it's been complexed with a chemotherapeutic agent. It's not one that is used in any other space. It's a chemotherapy that this particular company had on the shelf, and they, attached it to this antibody. Actually, in our disease, the antibody alone works. But because we're such a small group, the company didn't want to have a drug that would apply to just a small group of patients. And so they made the drug more powerful by adding a chemotherapeutic agent. And of course, it works extraordinarily well for Mycosis Fungoides and for CD30 positive lymphoproliferative disorders. So what happens is, you heard about the cells kind of waving the flag. So the cells waving the flag with the CD30, this stuff gets injected. It immediately goes to the flag. It attaches to the cell, and the cell engulfs it. And when the cell engulfs it, it allows the detachment of the chemotherapy from the antibody, and then the chemotherapy kills the cell. So it's kind of like a Trojan horse in a way, a very unique way of delivering chemotherapy to a cell, more specifically than just putting it in a vein and hoping it hits the right stuff. And there was actually a trial. We use acronyms for trials because it helps physicians remember which trial is which. This one's called the Alcanza trial. I couldn't begin to tell you what it stands for anymore. I don't remember. But it was a phase 3 trial, which is somewhat unique in our space. And it was brentuximab vedotin versus physician's choice, but it was really one of two drugs, either methotrexate, an old chemotherapeutic agent, or bexarotene, which is a retinoid. And these were patients that had CD30 positive Mycosis Fungoides or anaplastic large cell lymphoma of the skin. And there was a statistically significant improvement in the response rate that lasted 4 months. And so this drug, which was already on the market for Hodgkin's lymphoma, which is CD30 positive, for systemic anaplastic large cell lymphoma, which is CD30 positive, now it has an FDA indication for relapsed primary cutaneous anaplastic large cell or CD30 expressing Mycosis Fungoides. The reason that's important is that it's very hard for an insurance company to refuse you once you have an FDA indication. So a company goes through a long process, spending a lot of money to do this, and it actually helps all of us because then we don't have to argue so much about whether this is appropriate for a person or not. So this is a drug that's given intravenously once every 3 weeks. And here's the little cartoon. Not too exciting. Mogamulizumab is an antibody. It's against something on the cell surface, CCR4. CCR4 happens to be on T-cell malignancies. And this was a drug that came to us from Japan, where they have an endemic problem with a certain T-cell lymphoma. So it's of primary interest to them. But in this country, we don't see that lymphoma quite as much, but we do see a lot of Mycosis Fungoides and Sézary syndrome. So the study that was performed, which again was a phase 3 trial, so really, really important in our space. These are the first 2 phase 3 trials that have been done in pretty much all of research, with the exception of one trial in the 70s. And again, this drug surpassed the comparator arm, which happened to be vorinostat, an HDAC inhibitor that's oral. It's called the Maverick trial. And so this drug also is FDA approved for the use of mycosis fungoides and Sézary syndrome. And as I said, it works extraordinarily well to clean up people's blood. It doesn't work so well in some other compartments, but in the blood, it's really phenomenal. And so just a cartoon with both of these agents. Finally, so these PD-1 inhibitors, have people heard about PD-1 inhibitors? No. All right. This has kind of been in the press, and because it's kind of an exciting concept. In our space, I'm not sure it works quite as well as it does in melanoma or some other spaces, but however, people, tried to look at what the utility was in mycosis fungoides and Sézaries. So basically, we have an immune surveillance system in our body, and like stealth jets, tumors can fly under the radar so that the immune system just can't see them. And what these drugs do is kind of rev up the immune system to the point where it starts to see things that it has been neglecting, like lymphomas. And they're intravenous drugs. They're called checkpoint inhibitors. And so this was a particular trial that was phase 2, so it didn't have another comparator arm like a phase 3 trial. And there were 24 patients. Most of them had advanced disease. 2B is people with tumors. And they had a response rate and one person that had a complete response. And so it's of interest to see where this goes. There hasn't been a lot more information presented. Of interest, when you treat people with Sézary syndrome, the skin actually gets redder for a while. You can imagine the immune system kind of hitting all those cells all of a sudden, and the tremendous amount of inflammation that would occur from the immune system being so revved up and trying to hit something. So I throw it out there in case you had heard about these PD-1 inhibitors and what's happening in our space with PD-1 inhibition. And just kind of a picture. So it kind of removes the brakes from the immune system is basically what these drugs do. And then there's always clinical trials. Going through, every time I give one of these talks, I go through, there's a site you might have looked at, clinicaltrials.gov. It has every clinical trial in the US. It has most clinical trials that are elsewhere in the world. And sometimes it's just kind of fun for me once a year to look and see, is there something I don't know about or what's happening? These are studies that are either still accruing or going to be accruing patients soon. So just so you see that things are happening. And there's more than this. I just picked, the ones that I think are probably the most promising. Riziquimod is something that you put on the skin. It is a relative of a drug that's on the market called imiquinod, which weirdly enough is for venereal warts, but it works on mycosis fungoides. It works by generating interferon in the skin. Interferon is something we sometimes inject into people to treat mycosis fungoides. And this trial is actually close, but it'll go forward for what's called registration, that is FDA approval, probably within this year. The next drug is something called a SIK-JAK inhibitor. These are drugs that we use very commonly in B-cell lymphomas that are called small molecules. They are usually pills, and they inhibit a particular pathway in the cell that the cell needs to live. They're very specific. So this is just an example of one that might be going forward in the Tcell lymphoma world. Cobamarsin is a unique drug that's a microRNA. That means that the way that it works is by not changing the DNA itself, but changing how it's interpreted by the body. It's called epigenetics when that happens. And it's an injectable drug. And then anti-KIR3DL2 is another drug that works very well in blood. And I could keep going. There's a list. So just so you see, even though this is a small group of patients in the world, there's a lot happening research-wise.